Welcome to this session of the Center for Podiatric Education. I wanted to go a different direction with this session and talk a little bit about one or two of the modifiers that we utilize in billing, period. The reason for this is based on a personal philosophy. Many of the patients that are referred to the podiatric physician are referred with skin or nail problems such as onychomycosis or tinea pedis. We see a lot of geriatric patients and we see a lot of diabetic patients, and many of these patients have other pathology which is either untreated or unrecognized by other healthcare providers, and the responsibility falls on us to evaluate and treat patients for these problems. And the reason is obvious, and that is we know that in the geriatric and diabetic patient, many of these comorbid conditions can result in ulceration and infection and limb loss. Unfortunately, if the patient presents, for example, for nail care and they have a concurrent medical problem, there tends to be a reluctance to treat the patients for these problems because it requires an office visit, in addition to the routine care. So why is there a reluctance to treat patients for these problems and to charge for them? And I think most of it has to do with the fact that there is a general thought that if you start using modifiers together with a quote surgical procedure, close quote, that this will trigger an audit. And certainly we read with regular basis about physicians of all specialties. As podiatrists, of course, we read about podiatrists who undergo an audit and are found to have been non-compliant in documentation, or perhaps the documentation was not reflective of the services actually performed, and as a result there are clawbacks and paybacks and sometimes even loss of licensure or jail time. So this fear of audits is to some extent real, but to a large extent I think perhaps misrepresented and misinterpreted by many. And there are consequences to not using modifiers appropriately. So what are the main consequences? And it's either undertreatment of the patient, or you could treat them for free. So that you could say, I'd like to treat you for this problem, but unfortunately, if I put an E&M charge with your visit today for your nail care or skin care, this will trigger an audit, so I'm going to ignore the problem and place you at higher risk for complications. Or I could treat you and not charge for my time and not charge for my services. Or you could have the patient come back and you could tell the patient, well, unfortunately, your carrier does not allow us to do more than one thing for a visit, so even though you need a biopsy performed of that lesion, or even though you need treatment for your symptomatic neuropathy, or even though you need evaluation for your vascular disease, I'm not going to do that today. I'm going to trouble you and your relatives or neighbors or friends or whoever also took the time to come and see you because I'm fearful of an audit. Because this is the rat maze that all of us have been placed in by third-party carriers, including federal carriers, with regard to getting paid for our services. So what are modifiers? I want to talk about common modifiers, and more importantly, the two I think are most important in day-to-day practice, although there are certainly many modifiers. And even though we have countless practice management programs in our profession and online sites. It seems as though there still is misunderstanding of these modifiers, and there is still a reluctance to utilize these, and I would argue that these modifiers are absolutely critical for treating many of the geriatric and diabetic patients that we see. So a modifier is generally a 2-digit code. It's 2-digit characters that are added at the end of a CPT code. So you don't put it with your diagnosis, you put it with your CPT code. And it tells the insurance carrier, it tells the reviewer that there were special circumstances surrounding that visit and the use of that CPT code. They can be used to increase your payment, or they can be utilized to decrease the reimbursement if you feel that the services provided were less than would be implied by that CPT code. And I'm going to address the use of the CPT modifiers. I'm not going to address other common modifiers. In particular, I want to address the 24 and 25 modifiers because I believe in day-to-day practice these modifiers are the most common utilized and are the most important modifiers. So a 24 modifier means that you are charging an office visit during a time in which the patient would normally be covered by their global. For example, you've done a bunionectomy and you now have a 90-day post-operative global period. However, the patient may come in with a new problem, or they may come in with a problem that you are treating that requires monitoring that is unrelated to the surgery. In that case, you don't want your claim rejected because the patient has had, for example, a billing for an Austin bunionectomy, and now they're in their global period, and you don't want to be automatically be told, well, you cannot charge for any other services during that period of time. For example, you may be treating the patient for peripheral neuropathy. I think a more common example would be the patient who has received routine nail care, and perhaps you've placed them on a medication for an infection, and you need to evaluate their response to treatment during the, quote, global period, unquote, quote, following their nail debridement. The other common modifier, and I think really the most important one, is the 25 modifier. So this most commonly arises when a patient undergoes a procedure or an office visit that's considered surgical or procedural. And in podiatry, most commonly, it would be debridement of onychomycotic nails. It may be other things, such as a punch biopsy of a skin lesion. But you're also treating the patient for concurrent pathology. It may be some form of dermatitis for which you have prescribed a topical corticosteroid or some oral medication. It may be that you're treating the patient for neuropathy, and that is a very common issue. It may be a patient that you are treating for an arthritic disorder, such as Achilles tendinosis. So under those circumstances, you might be billing for their nail care, for debridement of their onychomycotic toenails, but at the same time, you may be actively treating them for an acute attack of gouty arthritis. And perhaps it's their initial examination for that problem, or perhaps you've seen the patient previously prescribed some colchicine or an anti-inflammatory agent, or given them an injection, or prescribed some topical agent, and you are evaluating their response to treatment. So under those circumstances, you would be billing for the procedure, perhaps reduction of their toenails, but in addition, you are evaluating and treating them for a separate problem, that being their dermatitis or their neuropathy or their vascular disease. And under those circumstances, you would bill an office visit at a level that you feel is appropriate, and you would also then append the 25 modifier attached to the CPT, the EM that day, stating that I'm seeing them for, in addition to their routine nail care, a separate problem. So what are the consequences of not using a modifier? Well, if there's no modifier and you bill for a procedure on that day, or the patient's in their global period, you're not going to get paid, because generally carriers will not allow and not pay for an EM service during the global period or on the day of a procedure without using the modifier. If you use the modifier with no documentation or poor documentation, meaning it does not justify the additional office visit, you may get paid initially, but on review, you'll at some point be required to return the money paid for that EM. And the potential consequences are obvious. There will be unnecessary claim denials. You will lose revenue. There is wasted follow-up time. You may be subjected to an OIG investigation or other evaluation by a third-party carrier. And most importantly, it denies the patient proper care. Many of our elderly patients struggle to get into our offices. They have to enlist a neighbor or a relative or some friend to take time out to help transport them. It is difficult for them to get in and out of their homes, in and out of the mode of transportation. They may have to be arranging some type of transportation or utilize public transportation. It's not easy for many of our patients to get to our offices. And now to deny them care and tell them, well, for fear of an audit, or because your insurance carrier doesn't want to pay for treatment of more than one problem at a time, I'm afraid I'm going to have you come back to this office with all the difficulties involved, when realistically we can care for all these problems at the same time, but I'm going to have to make proper use of a modifier. Now, there are many different modifiers that can be used under different circumstances, and at some point we can review all of these. But for this particular session, I want to concentrate on the two that I believe are the most important for the everyday practice of podiatric medicine and surgery, and that's the 24 modifier, again an unrelated evaluation and management during the postoperative period, and the 25 modifier, a significant evaluation and treatment on the same day that you perform a service. So to get it clear, the 25 modifier, what are you looking at? This should be a significant, separately identifiable EM service by the same provider on the same day of a procedure. So it may be that you've corrected an ingrown toenail by phenol and alcohol technique that day. It may be that you reduced their toenails that day. It may be that you performed a punch biopsy that day. If the patient has another problem that's unrelated to the correction of that ingrown toenail, it's unrelated to their toenail reduction for onychomycosis, it's unrelated to the punch biopsy, then you are going to be evaluating and treating an additional problem. Perhaps the patient says, on my other heel, I have pain when I get up every morning. Or, doctor, I've developed a dermatitis on my contralateral or even ipsilateral ankle, and it itches and it burns. Your note should reflect not just an additional diagnosis. It has to reflect that there's been an additional concern expressed by the patient, that you have taken the time to evaluate that problem, that you document that evaluation, that you've made a clinical diagnosis, and that you've initiated treatment. These are the same elements of documentation that you would have included in that note had the patient come to see you with the same problem, but you were not doing a procedure on that day. So, you append the 25 modifier to your EM code. So let's say you're doing an evaluation and treatment of a separate problem the same day as a procedure, and let us say your code would be 99213 for that visit. You would have -25, telling the carrier that in addition to that procedure performed that day, I am evaluating and treating a new concern or a different concern, doesn't have to be new, for that patient. So the problem has to be unrelated to the procedure, and that's the key. It can be a visit for a new problem or a problem that has changed or requires reevaluation. For example, you may be treating the patient for peripheral arterial disease. Perhaps you started them on silostazol. They've now been taking the silostazol for 2 months. You also placed them on an exercise program for claudication. You've recommended they discontinue smoking, and you've recommended they lose weight and better control their diabetes. Perhaps you've prescribed a topical anti-inflammatory with a home physical therapy program for Achilles insertional tendinosis, whatever. It has to be an unrelated problem, a problem that you are actively treating or are going to diagnose and actively treat. And these are the critical elements that must be included. So again, you attach the 25 modifier to the office visit, the EM code. It's got to be the same doctor on the same day of the procedure. And it has to be a procedure that normally would require evaluation and management. So if a patient comes in with an ingrown toenail, and you determine that you're going to remove the ingrown toenail that day, obviously there are certain elements that are included in that, particularly if it is a patient that is a known patient to the office, an established patient to the office for whom you have a background. The EM code may be prompted by the same diagnosis, so that it may be a patient that is in for an ingrown toenail, but there's a suspicion of peripheral arterial disease, and it's necessary to evaluate their vascular status before proceeding. If it is a new patient and you're performing an initial evaluation and management, that is considered separate from the same day surgery or procedure, and a modifier is not required for the new patient visit. So again, the 25 modifier is not something you should be fearful of. It is something you probably should be using much more than you are using, because many of our patients with diabetes, many of our geriatric patients are being co-managed by us for multiple problems, whether they're skin, or neurologic, or vascular, or musculoskeletal, or gait instability. So make sure it is a separate and significant problem that requires an evaluation and management by you the same day you are doing a procedure. The documentation should be the same as you would normally utilize for the same service and same evaluation, even if the patient was not there for a procedure. And be somewhat familiar with your carrier policies, because there are some payers that will not pay for both services at the same time, or will reduce the amount of payment. And what you do about that is going to be an individual decision based on the patient and circumstances and your considerations. But certainly, you do not have an obligation to provide free service for the benefit of the third-party carrier who's looking to profit and not provide you with adequate reimbursement for your time and services. Now, according to the American Medical Association, the 25 modifier is, quote, a significant separately identified evaluation and management service by the same physician on the same day of the procedure or other service. Make sure that your note indicates that the procedure was performed and that the patient's condition required a significant separately identified EM service above and beyond the other services provided. Again, the EM service may be prompted by the symptoms or conditions. For example, a patient may come in with history and physical findings that dictate the need for a biopsy, perhaps a nerve biopsy, an epidermal nerve fiber density test, or a sweat gland nerve biopsy. And this is going to be based upon your history and physical examination showing the presence of signs and symptoms consistent with or suggestive of a neuropathy. And there is no interdiction in proceeding with the procedure on the same day, but it's got to be clear that the E&M prompted the need for the procedure. The CMS policy for the modifier 25 is listed here, and that's if the patient's clinical documents indicate that extra pre-op or post-op work beyond what is usually performed was performed, it is proper to use the 25 modifier to indicate that extra work. Make sure that the clinical record clearly documents the extra or unusual work, and the provider should determine if the EM service for which you are billing is distinct from the procedure. I really don't think these are difficult conditions. I don't think they're difficult circumstances, and frankly, I think that this modifier is critical to treatment of certain patients. Let's look at the diabetic patient, for example. What is your job in treating the diabetic patient? It is beyond cutting mycotic toenails, and it is certainly beyond selling them shoes once a year. It is risk assessment, risk stratification, and interdiction and modification and treatment of those factors that can get your diabetic patient in trouble. So that it is unusual to be seeing a diabetic patient merely for nail care. Diabetic patients have an increased incidence of many skin disorders, of many neurologic disorders, vascular disorders, musculoskeletal disorders, gait abnormalities. Our geriatric patients have the same risk factors, plus issues such as fall prevention. And it's our job to evaluate and treat all of these problems and do the best we can to reduce the incidence of morbidity associated with lower extremity pathology. That is your job. And you should be reimbursed for the time. You should be reimbursed for the skill. You should be reimbursed for the knowledge. And unfortunately, the only way you can do that is one of three choices, really. One is you could abrogate all responsibility and do nothing. The second is you can tell the patient, I'm sorry, I'm going to inconvenience you, make it more difficult and expensive for you, but I'm going to ask you to return for another visit so that we could separately evaluate your other problems. Or you can simply use the 25 modifier, do what's right and treat the patient for their multiple comorbid conditions, and make sure that your documentation supports your decision to use the 25 modifier. The CMS policy states clearly that the 25 modifier should be used only when a significant, separately identifiable EM visit is rendered on the same day as a minor surgical procedure. Now, minor surgical procedure can include routine nail care. It can include routine skin care. It can include things such as a punch biopsy. For minor procedures, the determination to perform the minor procedure is typically made at that time, and generally an EM code is a little bit more difficult to justify other than the initial evaluation. So the 25 modifier, again, looking at CMS policy, is a separately identifiable service by the physician on the same time as a procedure. And basically you want to make sure that your documentation justifies that. So the question you ask yourself is, was a procedure performed on the same day as you have billed an EM code? If the answer is no, then there's no issue. You don't need a 25 modifier because you've just done an evaluation and management of a problem and a procedure was not done. If you've done a procedure, then the question becomes, was the EM code for a separate and identifiable problem? And make sure that means you have a history relative to that problem, you have a documented examination for that problem, you have an appropriate differential diagnosis for that problem, you've made a presumptive diagnosis for that problem, and you have initiated treatment for that problem. And if you have, then the 25 modifier becomes appropriate. So those are the things that you need to look at. Does your documentation support the patient's condition as requiring a separate EM? If so, does your chart reflect the necessary documentation? Does it define the medical necessity for the EM code? If so, then you go ahead and use the 25 modifier and bill appropriately. The other significant modifier that is absolutely required in treating geriatric patients, in treating patients such as the diabetic patient, is that of the 24 modifier. And that is the evaluation and management of a patient during a postoperative period or global period. So this can include significant surgeries such as a bunionectomy or a post-op excision of a neuroma or hammer toe surgery, pronation limiting surgery, a fusion, ankle joint replacement, whatever, or routine nail care. And the question is, does that patient require follow-up? Now, this can be for a new problem. So perhaps the patient underwent a surgical procedure and sprained their ankle, or developed a dermatitis, or developed numbness in their opposite foot, or some such thing. Or it can be a patient that you're treating on an ongoing basis for pathology. For example, you've reduced the nails on a diabetic patient, and the patient complained of neuropathy signs and symptoms, and you've elected to place them on gabapentin. And we know that that's a relatively rapid onset drug, and it's an elderly patient, and you say, I want to see you back in 1 month to evaluate your response to the gabapentin. I want to know if you're having side effects. I want to know if it is effective. I want to evaluate you for any adverse sequela. Or the patient comes in for treatment of their onychomycosis, and they have a monoarticular arthritis. You've diagnosed them with gouty arthritis. You've initiated treatment with an anti-inflammatory. They are diabetic. They're hypertensive. They need to be monitored not only for response to treatment, but for their risk of adverse events from the medication. And so you say, I need you back here in 3 weeks or 2 weeks to evaluate your response to treatment. So these are patients that are coming back to see you during their global period for a problem unrelated to the procedure. In this case, we'll say reduction of toenails for onychomycosis. Well, again, under these circumstances, the 24 modifier becomes the important modifier for you to use. So it is an unrelated service, meaning unrelated evaluation and management service, not an unrelated additional procedure, but unrelated EM by the same doctor during the global period, during the postoperative period. Once again, the 24 modifier is attached to the EM code. It has to be unrelated to the surgical procedure, which includes reduction of the nails, but it is being provided during the global period. It is being done, that is to say, the EM service is being provided by the same doctor. If that is the case, then you want the 24 modifier appended to your office visit, whatever level EM you think is appropriate. And here again, the critical issue is that it is a separately identifiable problem that requires evaluation and treatment. And you want to make sure that your documentation simply reflects that. There's no reason to be fearful of the 24 modifier as long as you're making legitimate use of that. And legitimate use means a separate problem that you're evaluating and treating. It may be you're evaluating the patient for response to their prescribed therapy. It may be that you are monitoring them for adverse sequelae or side effects. It may be that you're simply monitoring them for response to therapy, perhaps the need to modify their medications. So again, the question for the 24 modifier is, did you perform a service that has an attached global period previously? If you haven't, then the modifier is not appropriate. You don't need a modifier. If the answer is yes, I did provide a service that typically has a global period, and the patient is here during the normal global period for an unrelated problem, then you want to make sure that your documentation clearly reflects a separate problem, that you evaluated that problem, that you made a differential diagnosis, and that you initiated therapy. So there are certainly lots of examples of this. Again, I think a common one would be the patient that's being seen every 90 days for onychomycosis. However, you're actively treating them for peripheral neuropathy. And at the time of their last nail debridement visit, they were given a prescription for amitriptyline, 10 milligrams 3 times daily for their neuropathy. You've warned the patient about potential adverse sequelae, but you're concerned because they're an older patient and they have some multiple comorbid conditions. You're going to have that patient return during the global period. You're going to find out if they are having any anticholinergic side effects, any fluid retention, any dysrhythmia, any urinary retention, any problems, neuropsychiatric issues, balance issues, or other problems with the amitriptyline. You're going to want to know whether or not the therapy has been effective. You're going to want to know whether or not you need to modify their dosage. Perhaps they need a lower dose, perhaps a higher dose, perhaps some modification in frequency. So these are important things to monitor. The same thing with, say, gabapentin. As indicated earlier, it may be a patient that had acute onset of plantar fasciitis pain, and perhaps you initiated treatment with a night splint, perhaps a home stretching program, perhaps the use of an oral or topical anti-inflammatory, perhaps you prescribed that they seek physical therapy, and normally you would not see that patient for 90 days. However, you need to evaluate their response to treatment in the short term, evaluate them for any side effects from the anti-inflammatory. Perhaps they're diabetic or hypertensive or have a history of reflux, or there's some reason to place them in higher risk for cardiovascular issues. Under those circumstances, here again, it's not inappropriate to see the patient during the global period, but you must be certain that your documentation supports that separate EM visit, and that anyone reviewing that chart would clearly understand that you're seeing the patient for an unrelated problem. It's a significant unrelated problem, and it is not related to their procedure for which there is a global period. Lastly, I want to mention what is included in certain codes, particularly skin excision codes of the 1700 series and the 1100 series. Generally, the EM coding is included in the procedure code, so that if, for example, a patient presents for a biopsy of a skin lesion, the procedure code generally includes their skin history, prior treatments, and so forth, the indication for the biopsy, the obtaining of a consent form, as well as. So in summary, I think it's critical to understand that the treatment of many of our patients, particularly high-risk patients, the diabetic patient, the geriatric patient, requires a combination of both procedures and evaluation and management of multiple comorbid conditions. And this involves risk stratification, identification of risk factors, and then initiation of treatment for these various problems. This means an assessment of response to treatment. It means assessment of potential side effects. It means modifying drug dosages or frequency of drug dosage, or adding or subtracting various therapies. And you are entitled to be reimbursed for that time and effort. And I think that given the various modifiers that can be utilized, in my mind there is no question that the 24 and 25 modifiers are critical. They are not things that you should be fearful of. You know, there's that old saying, fear is false evidence appearing real, and I think too much has been made of this. If you are taking proper care of your geriatric patients and proper care of your diabetic patients, there is no question you will be making regular use of the 24 and 25 modifiers. The issue in my mind is taking the time to get away from these preset notes, these pre-populated notes, these micros and macros, and adding just one or two sentences to these preset notes and being EHR lazy, if you will. The key is to properly practice medicine, but unfortunately also having to take the time to properly document your decisions, not only medically but for billing purposes. So don't deny your patients care. Don't make it inconvenient for your patients to receive proper care. Do treat them appropriately, and make proper use of their modifiers.